course, everybody wants to be a healthy weight, but it does make it easier to get pregnant. We see IVF success rates lower in women who are obese.
It's interesting. One of the first patients I operated on, the reason why she saw us is because she had PCOS and she couldn't get pregnant. She did surgery with us, and then about a year and a half later, she was able to get pregnant.
When our bodies start to have off hormones, our estrogen is dropping, it becomes harder to lose weight or to maintain a healthy weight. Why is that?
Absolutely. As people go into menopause, they could start having fat around their abdomens, more visceral fat, and there's just a major disruption in the body.
Welcome back to the As a Woman podcast. I'm Dr. Natalie Crawford, and today we're diving into a topic that so many women struggle with, but often don't get clear answers about: weight, hormones, and metabolic health. My guest is Dr. Nicole Basa, a board-certified general surgeon and fellowship-trained bariatric surgeon who's the founder of BNA Medical Center here in Austin. She's known for her patient-centered approach to long-term weight loss and metabolic care, blending surgical expertise with a deep understanding of the hormonal factors that women face at every stage of life. Today, I'll discuss the connection between hormones, metabolism, and weight with Dr. Basa. We'll explore what you need to know about insulin resistance, what you can do to improve your metabolic health, and how to achieve lasting success from weight loss. Welcome, Dr. Basa. We're so excited to have you here today and talk about the challenges that all women face.
Yeah, so weight and weight loss, we all have a component of that. Like, we all want to achieve this perfect weight. We all have something in our heads that this is the weight I want to be at. And we all strive, every single one of us, I almost feel like, to try and be that perfect weight. And, our center is really dedicated. I'm a bariatric surgeon, so obviously I do surgery for weight loss, but it's really understanding your metabolism, understanding your muscle mass, understanding truly what that weight or that number is so much more than the actual number.
I think that's so true. And so let's start to dive in. We're going to talk about weight and hormones and insulin resistance and metabolism. And I think this is a big puzzle that so often people have a hard time really figuring out what these words mean, because especially on social media, there's so much misuse or there's trigger words when it comes to weight. But let's just start with metabolic health. And what do you consider your metabolism and metabolic health to be?
Yeah, so metabolic health is definitely your body's ability to burn calories. And it composes thyroid health, obviously fertility hormones, estrogen, progesterone, insulin. It has a lot of different factors that affect your metabolism. Genetics is a big one. If somebody has a slower metabolism than others, that could also be contributed by their parents or, that have given them that baseline metabolism. Really knowing true metabolism is really checking what your true resting metabolic rate. So actually in our practice, we do use indirect calorimetry to actually see truly how many calories do you burn at rest. So you can find
that out on your patients.
Yeah.
That's really interesting, right?
Yeah, and we do it oftentimes because people plateau. When you're losing weight, your body stalls. And even with our bariatric surgical patients, that occurs too. And so one tool that we do is we do a resting metabolic rate, which you breathe in oxygen, you blow out CO2 to really see how many true calories are you burning, so you can figure out truly how many calories you need to take in. And so a lot of times we see people are taking in less calories than they actually need, a lot less. And so that causes the body to stall in their weight loss. And so they actually have to eat more in order to lose weight.
So they have to eat more food in order to lose weight because they're not even eating enough to fuel what their body needs for its normal function.
Exactly.
And I think that's just so counter to what we've all thought about, right? We all think about starving yourself or just eating less, or it's all about calories. And you're saying it's really a much bigger picture of that because your metabolism is really the set point behind controlling how you're burning energy and the energy that you need.
Yeah, for sure.
We talk a lot about hormones on this show, and I think the hormones that you talk about sometimes are a little bit different than some of mine, because I know there's hormones like insulin and leptin that are really important to the weight conversation. Can you help the audience understand a little bit what these hormones are?
Yeah. So, insulin is a hormone that's released after we eat a meal So it makes us feel full. GLP-1, which is the big
very,
craze nowadays,
very hot,
is a hormone that's released after a meal to also make you feel full and cause different processes in your body to cause satiety or lack of appetite. So GLP-1 is a big one. Peptide YY is also a hormone that's released after a meal, released from your intestines, that also make you feel full. And then there's hormones like ghrelin, which is secreted from the stomach, which when you're hungry and you haven't eaten for a while, it's in super high levels. And what we've actually seen in bariatric surgery is by surgically changing someone's anatomy, it actually affects all of these hormones, where ghrelin drops, which is a hunger hormone, and GLP-1 actually increases.
From surgery.
From surgery.
That's crazy.
Yeah.
And so they're changing their hunger cues and their fullness cues.
Exactly.
How do our cues get messed up when we overeat and when we don't have that sensation that we are full? What happens inside our body?
So, if you eat a meal, typically insulin's released. If you're overweight or obese, you can secrete insulin, but then your cells have insulin resistance and they can't sense that insulin in their body. And so therefore they could not feel that satiety or that fullness feeling. So it definitely can disrupt things if you're overweight.
So even just being overweight or having insulin resistance, because I know we've got PCOS patients who might have insulin resistance and not necessarily have obesity associated with this, can interfere with your own cues and your hormone signals within your digestive system to tell you, hey, you've had enough. It's time to stop. Insulin resistance is so interesting because it also causes a lot of inflammation in the body and it can interfere with your reproductive hormones. So besides just the GI hormones, and when it comes to this food cycle, we see that insulin resistance interferes with estrogen, progesterone production, and obviously that can interfere with ovulation and getting pregnant and things that people are trying to do. What about weight changes when it comes to hormone changes? Because I know when things like perimenopause, menopause, when our bodies start to have off hormones, our estrogen is dropping, it becomes harder to lose weight or to maintain a healthy weight. Why is that?
Absolutely. So as estrogen drops, actually our bodies become less sensitive to insulin, and you actually can develop some insulin resistance. And that's why as people go into menopause, they could start having fat around their abdomens, more visceral fat, and there's just a major disruption in the body. Also, another thing is cortisol. The stress hormone also increases, and that can also cause insulin resistance and difficulty in losing weight.
So we have these hormone changes that are happening because our ovaries aren't making as many hormones anymore. But then this has so many different impacts on our body. And this can happen in the perimenopause phase, not just menopause. I think we're seeing this more as people are talking about it, but people tend to think some of these changes are only impactful to them once they hit menopause and have no estrogen, not in this time period where you're having fluctuating hormones. But you see this a lot as women start to get into perimenopause, this being a big issue.
Yeah, absolutely. I see, number one, changes in your metabolism. It changes. Again, that insulin resistance starts to occur in your body because of the drop in estrogen. So yeah, I definitely see it in a lot of our patients. Actually, the inverse too, in morbidly obese patients, as you know, fat cells secrete estrogen.
I know.
And so then it messes everything up. But, the fat cells secreting excess estrogen can also lead to cancers, can lead to colon cancer,
endometrial cancer.
Yes. So it causes disruption in a lot of different things.
I think that is an important thing to think about. We can talk about weight and fertility. And I know that this is a really sensitive topic because when it comes to getting to a healthy weight, of course, everybody wants to be a healthy weight, but it does make it easier to get pregnant, partly because of some of these hormone issues, because of ovulation issues, but also implantation issues. We see IVF success rates lower in women who are obese. But I think that there's this balance between time and the time it can take to lose weight and the time that we feel with fertility. So how do you approach patients maybe who are trying to get pregnant but who are overweight and balancing on that scale?
Yeah, so it's interesting. One of the first patients I operated on in Austin when we started our practice back in 2008 when I did her surgery, the reason why she saw us is because she had PCOS and she couldn't get pregnant. And so she did surgery with us. And then about a year and a half later, she was able to get pregnant. And so I see it a lot. And I even see it in people who have done IVF for a very long time. They could not carry, the implantation. They couldn't carry the baby. And then they're like, okay, I'm going to focus on myself. I'm going to do weight loss surgery. I do surgery on them. And they actually have a natural pregnancy.
That's amazing.
Yeah.
Well, I think it's just showing that weight is definitely a big piece of the picture, but it's also these hormone changes that sometimes go hand in hand, but sometimes they're independent. So if we think about PCOS, because we both mentioned that, right? We know that PCOS is typically defined as having 2 out of 3, irregular or absent cycles, kind of some of these androgen, these male hormone increases, and then a high number of follicles. But none of that really explains what is happening on the back end, which is this insulin resistance, abnormal estrogen progesterone production, which ultimately lead to weight gain, which worsen the insulin resistance and the abnormal hormones. So PCOS patients get into this cycle that really can present them with difficulty ovulating and getting pregnant.
Yeah.
When it comes to women who often say, I'm doing everything right. I'm really trying to cut calories. I'm really trying to do all the high intensity exercise. I'm doing everything I can, but the scale won't budge. I'm sure you see this every day in your practice. Where do you start with that?
Yeah. So first off, I actually asked them, do you eat breakfast?
Okay.
Like, what are your meals? What
Well, because
do you
intermittent fasting is a big thing.
Right.
Okay, so tell us about breakfast.
And I can tell you almost 100% of the patients who I ask them their meals throughout the day don't eat breakfast. The majority of my bariatric surgical consultations
Before you see them, they are overweight and they do not eat breakfast.
Yeah, so I basically ask them, tell me your typical daily meals. And then I say, okay, what do you eat for breakfast? Oh, I skip breakfast. Or I drink coffee. They don't basically...
I'm feeling really called out right now.
A lot of them don't eat breakfast. And, you really need to break the fast and start your metabolism going by having something, even like a protein shake, whatever it is, for a morning. So it's really interesting that they mention that. So first off, I kind of see what they do. A lot of patients actually eat predominantly one big meal a day. Maybe they eat a little bit for lunch, but their dinner is the hugest. So, we have a dietitian in-house, so they actually will consult with our dietitian. If they tell me they do HIIT training, they do 10 hours a week or something crazy, and they work with a personal trainer and do all this stuff, I look at, okay, what type of exercise are they doing? Are they doing all cardio? I could tell you
Probably
the majority
yes.
of people,
because that's what you do to lose weight. I mean, as we've grown up and been told.
Yeah. So a lot of them do running, they work out a lot, they do HIIT. And really, it's about muscle. And I think we don't focus on doing resistance training. Like muscle building is for guys or something like that. So really honing in, do they lift any weights? And I can tell you the majority of the ones I see don't. So that's another thing. And so in terms of what I do as the next steps, I have them see our dietitian.
Okay.
Then we also have them doing a resting metabolic rate. We do a body composition. So we have
that sounds terrifying.
I know. So we have a scale that basically through bioelectrical impedance, and we have ultrasound on there, it can detect how much muscle you have, how much fat you have, and actually the location of muscle in your body. So your arms, your right versus your left, your right leg, left leg, abdomen, like everything. Water percentage, visceral fat, all of that. So we do one of those to kind of see, do they have enough muscle mass? Do they have too much fat percentage? All these different things. And then we have an exercise physiologist too, who will work with them. And if they have low muscle, then he does one-on-one training with them. We have little gym area in our office. So, it's basically not just surgery. It's not just the GLP-1 meds. It's really focusing on what this person is doing. Maybe they're working so hard, but not the right way.
Okay. What I'm hearing from you is that the classic, my weight's not budging, but I'm doing everything right person is eating too few calories, not eating breakfast and not lifting weights. They're doing more cardio activity.
Yes.
So it's not that they're sitting around just eating everything in
no.
sight, being lazy.
Yeah.
People are actually really actively trying.
Exactly.
But these 3 things that we've been told are the keys to weight loss are really not.
Yeah. Yeah. And
Isn't
it's
that
really,
crazy?
I know, it's really our job to kind of help them and figure that out. And I think a lot of us just do it, by, I don't know, watching videos, reading different things, listening to different things. But really having a guide and accountability can change that whole stage that you're on to try and lose weight.
Let's talk about what you can do. So you already set the stage here. So maybe you're hearing this and you're understanding that your weight and your metabolic health really impact your hormones and your longevity. This is much more than being small or having an aesthetically pleasing body. It's about having a stronger body that functions better, that can last longer, right?
Absolutely.
So what are the keys to starting, let's say, what is a healthy weight? How does somebody find out what's a good healthy weight for themselves?
So you can go based on body mass index, which I really don't like at all.
It's kind of controversial.
Yeah, it's just weight and height. So, if your body mass index is over 25, then you're considered overweight. If your BMI is over 40, which is the kind of the standard of where we operate and do surgical weight loss, that's considered as morbidly obese. But really, I think to know exactly what weight you should be, and I actually had a conversation with a patient yesterday because I looked at her actual BMI, which looked great, but her muscle mass was like in the 3rd percentile of her age range. Like it was really low. And her fat percentage was about 36%. So for women, you want to have a fat percentage of less than 30%.
Okay.
And then for men, a fat percentage of less than 25%.
Okay.
So if you can do that, regardless of whatever that number is on the scale, then you'll be healthy.
Okay, so it's more about composition than just pure number on the scale.
Exactly.
Can people get a scary scale that measures this composition on their own, or is it best done in a professional's office?
So it's best done in an office setting because definitely our scale is not something you buy over the counter. And to tell you the truth, we have an ultrasound to actually detect height.
Oh,
and,
so you're getting the real height, not just...
And a lot of people lose an inch or so, and I just say that's normal, it's fine. But you could... the ones that you get like off of Amazon or stores probably are not as truly accurate. You could use it to kind of just guesstimate, but I think really coming into a physician's office is probably the best way.
Going to be the best way.
Yeah.
Tell me about, we've talked about some lifestyle stuff and we're going to get into medications and surgery, but we're talking about what you can do. And you've said these words a few times, but really kind of talk to us about muscle mass, protein intake, movement, and some of these things that we control about our day and our body and the choices we make. What should we be doing to set ourselves up?
So definitely getting enough protein.
Okay.
So, generally you want to get about a gram of protein, 1 to 1.5 grams of protein per kilo of body weight. What is that in general? About 80 to 100 grams of protein a day. Okay. So that's about 4 servings of, a small chicken breast is about 80 to 100 grams. So number one, you have to have the substrate to create muscle. Then
which is protein.
Which is protein, exactly. And then do some sort of activity that stresses the muscle so that it can build. So, whatever, and I talk to patients about this. I'm like, do you exercise? Or like, I'm doing this and that and this and that. I have no time. I can't do it. And I say, just, 20 minutes. Just do 20 minutes, wake up 20 minutes earlier.
I say the same thing, just 20, right? We don't have to shoot for a whole hour or some crazy number.
Exactly. In case in point, myself, like over the last year, I would wake up 20 minutes earlier. I would do what I tell my patients, and I just feel so much better. Mm-hmm. And to tell you the truth, I actually just checked my lipid panel not too long ago. And my HDL was like 85, and before it was like 65, and then my triglycerides were really low compared to like 4 years ago when I checked my lipid panel. So I think just doing a small amount, but be consistent.
And this is really to build muscle. So you're seeing these changes on your cholesterol panel, more good cholesterol, less bad cholesterol.
Exactly.
Because you are building muscle, which is fighting insulin resistance, helping your hormones function better, helping your gut health better, right?
Yeah.
And so by just doing the 20 minutes with a focus not to lose weight, but to gain strength and to gain the muscle mass, it sounds like, really should be the key.
Exactly. And I think we're just too focused on that scale number. And that's not health. That's not true health. It's really how your labs look, you know, how you're feeling, all of that thing. All of those things are really what constitutes good health.
Is movement, when it comes to movement and what you can do, are all weight training exercises created equal? Is it lifting weights? What about the weighted vests? So what kind of thing do you recommend people start if, let's say, they're doing nothing or they've been a cardio heavy person and weights seem really intimidating?
Yeah. So I would, you know, alternate basically upper body and lower body. Core you can pretty much do every day. Even you do 5 to 10 minutes of like some core exercises. You could even do Pilates or things like that, yoga to strengthen the core. I would say don't reach for the moon. Like I see all these, you know, videos of people going to the gym, lifting these heavy weights. Just start with a couple of, you know, 3-pound or 5-pound free weights. But the key thing I think is you need to be observed. I think a lot of times people start working out and doing weights and they're not doing it correctly.
By themselves in their house, like me again. Okay. So a trainer, maybe invest if you have the resources for at least at the beginning for somebody to teach you how to do some of these exercises correctly.
Exactly. That's what I would say.
Okay.
So.
Well, let's talk about, we know people do need to lose weight. So there's one idea to kind of get things shifted if you've had a plateau or if you've just gained some weight from perimenopause, and some of these tips as far as eating breakfast, eating more protein, trying to build muscle mass. That's the foundation for everybody, it sounds like. But if you need to lose weight to kind of get into that healthy weight range, let's talk about GLP-1s, because meds like Ozempic, they are all the rage right now. Can you explain what they really are and how they help?
So GLP-1 is a hormone that we create from our intestines that increases after a meal. So a GLP-1 receptor agonist is a medication. You have to inject it. It's once a week. And it binds to the receptors that your own body's GLP-1 binds to.
Okay.
And those receptors are located in your brain. So you feel full. You just can't even stand any another bite. The receptors are also in your pancreas to increase insulin secretion. And that's why GLP-1s were receptor agonists were used for diabetic patients to increase insulin secretion.
Okay.
It also slows down your GI tract, including your stomach. So you feel full because your stomach's not empty.
Because you are full.
Because you are full, yeah. So these GLP-1 agonists were used a lot for diabetics. And just recently, well, not that recently, I guess since probably 2021 or 2022, these drugs have been used in patients who are not diabetic, and what they saw was dramatic weight loss. So who do we look at to use GLP-1 receptor agonists? Well, you know, if they're doing all the foundational things like we just talked about, and they're still unable to lose weight, then a GLP-1 could be warranted. Definitely do it for patients who are, you know, BMIs above 25, 28, actually, 30, something like that.
So maybe not surgery level range, but overweight.
Right, exactly. Because in the studies, people lose about 20% of their body weight. That's the highest amount, typically with tirzepatide, which is the stronger medication. It's also Mounjaro or Zepbound. So if somebody's 300 pounds, they would lose about 60 pounds on average. So they get down to 240. So definitely somebody who's higher BMIs of 40 or above, definitely surgery is really the gold standard for those patients. GLP-1s, I don't necessarily use those unless, you know, maybe they had a surgery and they need additional help to get down the last bit. then maybe GLP-1s are warranted in those individuals, because obesity is a chronic disease. And I think just as we think of cancer as a disease process, you have to think about obesity the same way. And if somebody has a BMI 40, 50, 60, you have to attack it in different fronts. You know, one thing may not be the only solution for them. So.
That's such a good point. When it comes to GLP-1s, you know, what are some risks or some concerns you have if people are on them, or something you might warn patients about?
Yeah. So some of the common side effects is nausea and vomiting. So because your stomach is not emptying properly, it can cause you to throw up. So that's one key thing. The contraindications to those medications, there's two: a history of pancreatitis, and then the other one is a thyroid carcinoma that's genetic, which is medullary thyroid carcinoma. Okay. Those are the two subsets that should not get a GLP-1. What are other things that I've seen? I've seen just, you know, random abdominal pain, cramping, you know, that there is no, you know, if they go to the ER, nothing's necessarily seen. It can cause pancreatitis. And then, you know, I think that's really the reason why you shouldn't have had pancreatitis, because you're more prone to that. So those are some of the side effects from it.
And then if somebody's on a GLP-1, do you have a different advice for their weight loss journey than somebody else, or is it the same kind of core principles?
Yeah, so it's the same core principles. What I've seen, because actually we do prescribe and we do treat with GLP-1s in our practice, is looking at the body composition and making sure when they lose their weight, they're not losing all their muscle. And what I've seen in some of the patients we've had on it is they lose quite a bit of muscle, and they lose actually more muscle percentage than our bariatric surgical patients.
Oh, interesting.
Which is really kind of crazy. And I think it might be part of, they're just not getting enough nutrition.
Because they're not hungry, so they're not eating.
Exactly.
So it sounds like if you're on a GLP-1, really prioritizing some of that protein and weight training, resistance training to try to keep that muscle mass so you don't lose it.
Absolutely.
When it comes to bariatric surgery, you talked a little bit about it earlier, telling us that, you know, by changing our anatomy, you're actually changing hormone function, and that patients with a really high BMI are good candidates for it. I know so many patients we share who are really, really terrified about it. What do you say to these patients and say, like, this is truly might be the best option for you to have health and longevity?
Yeah. So, you know, I say to patients, obviously it's a surgery, right? We all don't necessarily want to have surgery, but the risk of dying from a bariatric operation is less than 0.01%. It's really low. We do it minimally invasive. So I do all my bariatric operations robotically. So they're small incisions. They're
no big incisions.
No big incisions. Yeah. They're up and walking within a few hours after surgery. We actually use long-acting local anesthetic for their abdominal incisions called Exparel. So it actually lasts up to 3 days. So they're just kind of sore on the abdomen. And so the safety is definitely there. And I think the other thing to kind of contrast, you know, surgery versus GLP-1s is surgery is kind of like it's a long-term solution. GLP-1s, unfortunately, if you stop them, you'll most likely regain your weight. So if you want more of a permanent solution where you don't have to take meds for the rest of your life, definitely surgery is probably the best way to go.
But surgery, just like GLP-1s or anything, you have to change your lifestyle in addition.
Absolutely.
What are some keys that might be specific to patients who have bariatric surgery? I know there's some, you know, nutrition or vitamin needs that might be a little bit different that they have to keep in mind.
Right. So definitely, like we talked about, protein is key. So I tell all of them to average about 80 to 100 grams a day. Drinking enough water is super important, even for metabolism and for you to burn fat. So drinking at least 64 ounces of water a day is important. And then taking specific bariatric vitamins. So we do different types of procedures, some that can cause potential deficiencies in vitamins. So they have to take specific bariatric ones that increase, you know, your iron, your calcium, your B vitamins. those are all important. So you can't just take an over-the-counter one-a-day women's. You actually have to take a specific one for the procedure you've had.
And then when it comes to, I want to get pregnant, but I need to lose weight. And let's say somebody is taking that break and they're going to lose weight. How long do they need to wait, let's say, after they stop a GLP-1 or after they have surgery before you say this sounds like a safe time to get pregnant?
So in terms of the GLP-1s, it's hard to say exactly how long after they stop it, because they might, if they stop it too long, they may regain a lot of the weight that they lost. And then have
make them be off for 2 months before an embryo transfer, due to unknown fetal impact of it. But I think this is a balance because patients lose a lot of weight. They don't want to come off. So I think it's harder. It's one thing to do an embryo transfer. It's another to then go back and try naturally, which might have a 10% chance per month.
Right. So, but for bariatric surgical patients, I tell them to give themselves at least a year and a half to 2 years. I mean, the longer they can stay at that weight that they want to be at, the better you can recreate your set point. And set point's a big thing with weight loss. And honestly, that's the reason why we constantly yo-yo when we try to lose weight, is our set point. And our set points can change throughout our life. And it's just like, you know, if your set point is a certain weight, you try and lose the weight, your body freaks out and it actually slows your metabolism more so than what it should be based on your body composition at the lower one.
Because it wants to be at the set point.
Yeah, it wants to go back up.
So this is why people say, well, my body just likes to be at this weight. There's some truth to that statement.
Absolutely, 100%.
Okay, well, how do you change your set point? What is the key there?
So it is very difficult to drop your set point and recreate a new lower set point. Our bodies are great at recreating higher set points.
That's inconvenient.
Yeah. I guess it works in a place where you have no food, you know, and you starve and you lose a bunch of weight. Then you get to civilization, you can regain all that weight back. But in our society where you can, you know,
get food,
Uber Eats or whatever, and you get food readily, it's not so great. So studies actually show, there's actually a study on comparing Biggest Loser contestants who did the whole, like, eating a lot of protein, working out with a personal trainer, trying to preserve muscle mass, and they compared those patients to gastric bypass patients. And they wanted to see what happens to the metabolic rate. And what they saw in the people who lost weight through diet and exercise, you know, eating right, they saw a slowing in their metabolic rate of about almost 800 calories less than what they should actually be at based on their body comp.
Wow.
So there was a huge deficit. And even though they actually have had enough muscle mass and they didn't have much muscle mass loss, in bariatric patients, they saw that there was a drop also in their metabolic rate, but it bounced back a lot quicker than the ones who did it with intense exercise, dietary changes and stuff like that. And so from that study, it showed that it actually took over 6 years to reset a set point to a lower
6 years.
one.
So this is a journey, not just a couple month fix.
Yes.
You really are going to have to say, this is a change for life.
Exactly.
All right.
Exactly.
Well, Dr. Basa, this has been so fabulous. I do want to ask you one last question, and that is, what is your one key piece of advice for somebody for their health? What if you could have all women do one thing or one piece of advice you'd give everybody? What would that be?
My one piece of advice would be to definitely eat protein.
Okay.
Definitely drink a lot of water. You know, it's not one piece of advice. It's just basically doing little steps in your life, be it the exercise we kind of talked about, 10 minutes, 20 minutes, but consistency. Just keep at it. And even if you feel like things are not going right, like the direction of the scale is not going right, you are making changes in your body that will build over time and it will make you healthier.
Okay. And where can people find you if they want to see you as a patient or follow you on social media?
Yeah. So my social media on Instagram is Nicole Basa, MD. We're a kind of like a destination clinic in Cedar Park, Texas. We're about 10 miles or so from downtown Austin. So you can come to our website, bamedicalcenter.com, to find out all the different services we have.
I love that. Thank you so much for being here. And thank you, everybody, for watching and listening to this week's episode of the As a Woman podcast with Dr. Nicole Basa, talking about your weight, hormones, and metabolism. It sounds like the key takeaways I'm hearing here is small changes every single day can make a really big difference. So eat breakfast, focus on protein, and work on movement to build muscle. Don't have everything be about the number on the scale, but it's about the composition of your body.
Absolutely.
Thank you, Dr. Basa.
Thank you so much, Natalie.
Thank you for listening to the As a Woman podcast. If you're ready to take control of your reproductive health, my new book, The Fertility Formula, is your next step. It's a science-backed guide to understanding your hormones, optimizing your fertility, and owning your reproductive future. You can order your copy and learn more at nataliecrawfordmd.com/book. And as always, follow along at Natalie Crawford MD for even more support. Because knowledge is power, and your health deserves a formula made just for you as a woman.